Hello, good evening. Thanks a lot for joining us for a session on Nobody Left Outside, Access to Health for Marginalized Communities. And thanks for people joining online. I don't know if somewhere there will be a number or maybe not, but you're welcome to address your questions to the panels and participate in the conversation. This is actually the 5th year anniversary of Nobody Left Outside, an initiative that was started at the European Health Forum Gastein back in 2017. And back then, it was probably one of the most groundbreaking sessions that was organized at the European Health Forum Gastein. And it's not just because I participated in it, and some of the founding members were there as well. It was something that a lot of public health people who I see as role models told me, actually, because we brought the voices of the most, or some of the most marginalized communities to talk and share about their challenges in accessing healthcare and health services. And it was basically very simple. People representing migrants, homeless people, people who inject drugs, sex workers, LGBTQ, and prisoners. And they just were sharing their stories and their challenges in getting access to appropriate healthcare. And the fact of putting all these voices together on this particular topic was quite striking and was a lesson for me, because I realized that whatever society, policymakers, leaders and people in general have as prejudice regarding any of these communities, when we're talking about access to healthcare and the challenges faced by these communities, anybody will immediately think in public health terms. And the prejudice just drop out because you identify commonalities and a real issue of health equity. So this is really at the core of Nobody Left Outside. And for the last 5 years, thanks to fantastic founders, and they will introduce themselves, and online you can see the full list. The coalition has been extremely busy. There's a lot of activities, both in terms of advocacy, engagement, but also developing reports to inform policy. It has been recognized by the European Commission as a health thematic network in 2019. It is the go-to coalition for the WHO Europe when they want to get input from the people representing those marginalized communities when it comes to the response to COVID-19 and other issues. And so very soon there will be an event on mental health where Nobody Left Outside and members were able to contribute. So this is, in very, very few words, what NLO is about. And so last year, because of COVID, what we did was, and the idea of the European Health Forum Gastein was, they really helped us and they welcomed NLO for the last 5 years. And the idea became that rather than having separate panels, we should really try to insert the voice of NLO across all the debates taking place at the European Forum Gastein. Hence the idea of having a late night meeting, and we will meet tomorrow as well to discuss and to hear from representatives what they thought about what was discussed. So last year it was online. We had, three sessions, and this year tonight and tomorrow night we will have those discussions. So maybe we don't have that much time. So maybe we do a quick round so you can introduce yourself, which will be done much better than I can, and also say, what did you think about today's debates? And one thing I will say, there was a plenary about perma-crisis, and to me it struck me suddenly that, well, if there's something that we can talk about in terms of, or call a perma-crisis, it's really the situation, the challenge of addressing health needs for marginalized populations. And that has been a perma crisis that the longest running. So please.
Thank you, Boris. My name is DOROTA SIENKIEWICZ. I'm a policy manager for EuroHealthNet. For those of you who do not know EuroHealthNet, are not familiar with us, we are a European partnership for improving health, equity and well-being. We are a network of mostly national public health institutes, health promotion agencies, universities, research institutes and practice organizations. And we work on the issues related to policy, exchange of good practices and research activities, with a strong focus on reducing health inequalities by investing in socioeconomic and other underlying determinants of health. Shall I say what struck me today? Oh, well, I spoke at a very early morning session this morning on the co-creating food systems, or sustainable, healthy food systems, I'd say. But then throughout the day, I'm not sure I actually heard the voices of the most deprived populations in our societies, those who have always been there, and and on the top of these, we get new groups entering the picture and having to be dealt with on a rather quick in a rather quick way. So yeah, just go quick. Yeah.
Oh, you have microphones, so maybe we can just turn them.
I'm good with this one. Hi everyone, I'm JULES JAMES. I'm replacing Luca, who was supposed to do session tonight, but is gonna do it tomorrow. I'm a sex worker and I'm also a program officer on health and well-being at the European Sex Workers' Rights Alliance, ESWA, and that is also part of NLO. And I'm very happy to speak to you tonight about a session that struck me today. I'm kind of new in the organization, but something that I'm very interested in is data and how to collect data, because we're kind of in a loop as sex workers where it's very hard as criminalized population to have actual data, because we are mixed with other marginalized groups, or our data simply don't exist. They are not monitored by states or other bodies. And sex workers also hide, so it's quite hard to have data. And on the other hand, it's quite hard to do advocacy work where we don't have data, and it's hard to correlate different factors also with health. So on the session on data, what I found very interesting is how to use those data in an efficient way. That's like the smart card idea that was brought. I found it quite interesting that maybe like for migrant sex workers could be useful when they cross countries, also to deal with language barrier, for example. But also a big question is how to protect data on stigmatized populations. And we have to know, like, when we go to a doctor as sex worker, usually it's put in our medical folder, and this can have impacts with the next health care professional. And I'm not only talking about sex work, but I'm also talking about what about drug use written in medical folder, what about having HIV, which is also stigmatized, but also simply what about abortion or contraception, how these data can be used, but also can be used against us in certain contexts, for example, being mistreated in medical contexts. So that's what struck me today. Oh, you have another microphone.
We have to use our own microphone. It's a COVID measure, maybe.
I don't know.
Yeah, I'm a bit sick, so it's better.
It allows,
but it's not COVID.
So if you disagree or if you have a question, you can ask or challenge your neighbor.
Okay, my name is FREEK SPINNEWIJN and I'm the director of FEANTSA. FEANTSA is an organization that works on the issue of homelessness. And for those of you that struggle to understand what homelessness is, maybe I can say how many people we think experience homelessness in the European Union. It gives you an idea. It's a very marginal problem, but it still affects quite a large number of people, in our view. We think that there is probably around 1 million people that experience homelessness on any given day in the European Union area. So it gives you like a sense of how big it is. Actually, Germany, the German government just released today, for the first time ever, their number, what we call point-in-time number, like how many people were homeless during the period of a week earlier this year. And it's 270,000 people that are in shelter, on the street, or forced to sleep with family and friends. So it gives you an idea. Before I say what struck me today, maybe just try to answer one of the questions that was put to us in the briefing, you know, like what needs to be done to make sure that nobody is left outside or that nobody is left behind. You know, I think the answer is very simple. We have to make policymakers, but also services aware that they exist. You know, like I'm now 20 years of FEANTSA and I constantly have to repeat that these people exist. They just don't fall under the concept excluded people, because excluded people has sort of lost its meaning. It's like people are very, very excluded and they're constantly overlooked. So we have to make sure that people are aware that they...
And maybe on that, FREEK, you can remind us also of the very striking example of the start of the pandemic and what happened in terms of, you know, lockdowns for people, you know, living in homeless situation.
Okay, but I'll try to answer that in a minute. But just on the point of we have to make sure that they exist. And when I heard Commissioner Kyriakides at the session, what was it, the perma-crisis session, saying we have to look at the glass half full, you know. Yes, we have to look at the glass half full, but the people that we work with are always in the empty bit, you know, like it's really difficult to be positive when you're always in the empty bit. I think the assumption of the commissioner is that when the glass is half full, everybody benefits to some extent. But it's not true. Like the populations we work with, they're always out of the loop. So, but it's true, during the pandemic, you refer to the pandemic, homelessness was suddenly a public health issue. It was actually a public health risk in a way, because there could be vectors of infection. And so it's amazing what happened during that period. Like in a matter of weeks or months, almost all people that were sleeping rough were put into shelter or other forms of accommodation. This was something we thought was possible, but maybe it would take 10 years to get there. And then during a health emergency, it can happen in no time. You know, the problem with health or a social problem as a health problem is that you make progress when it is a health emergency. Now that we're not in a health emergency anymore, or at least that's how policymakers pitch it, we're back to the old normal. I'm as surprised by how quickly we're back at the old normal as how quickly we got people off the street and into proper accommodation. So I think the challenge for us is how can we pitch homelessness as a public health issue, but also when there is no health emergency. I think that's the key issue. Now, very quickly on what struck me today, on the food. It's very interesting to hear about sustainable food systems, and we have to encourage people to eat more healthy and more sustainable food. But from our perspective, you know, homeless people in shelter, they don't choose their food. They're often dependent on soup kitchens. Like, you have to also keep that in mind, you know. But even the people that are not even homeless, but at the bottom end of society, you know, when you're living on a minimum income and you're in debt counseling, in my country, in Belgium, you get 50 euro a week per person and 20 euro for a child to pay for and your food and your personal hygiene. Try to live healthy and sustainable, to eat healthy and sustainable with that kind of money. I'm not saying that we don't have to do anything about it, but you have to make cheap eating, healthy eating cheaper, you know, for these people, because otherwise the situation will become worse.
Or cheap eating healthier.
Yes, indeed, yes, sorry. I also attended the session on cancer. It was a session especially on inequalities. And what struck me, and sorry to be a bit provocative, is that those stakeholders in the room that are key to deliver on less inequalities in the framework of the Beating Cancer plan of the European Commission and all the focus on cancer by the European Union, they don't have marginalized communities at all on their radar. They talk about health inequalities without thinking about homeless people, undocumented migrants, sex workers, etc. And I don't think it's bad will. Like that's not, but it's just unawareness. So it's back to my first point. We have to make even the people that are interested in health inequalities aware of to what extent health inequalities is a reality. And the last thing I want to say is I'm really impressed by the ambition and the dynamism that comes from Commissioner Kyriakidis and Mr. Kluge from the World Health Organization Europe office. But it's so little concrete, you know, like you have to concretize. When you say we want to reach everybody, we don't want to leave anybody behind, you have to concretize that. If I look at the EU, it's good that health inequalities is a focus for the Beating Cancer plan. But in the overall program, the EU for Health program, health inequalities is not even a priority. You know, like you have to deliver what you say, and I think there is quite a bit of scope for progress there.
Let's come back.
Yes, yes.
So, Abby, your turn, please.
Thanks.
Obviously, as you see, we have a panel. We have a mixed panel. We have members of the Nobody Left Outside community, and then people who were participating in previous panels and bringing another perspective. And that's the purpose of this event, is also to have a conversation and opportunity to share ideas.
Thank you. So my name is Abby Perry. I'm the director of the Nutrition and HIV division for the World Food Programme. I was, in a way, quite surprised to be invited to this event, when what we do is fundamentally work on trying to support the poorest and most marginalised in the poorest countries in the world, rather than thinking about the Europe context, I mean, with a couple of exceptions. I think, it's been gratifying in some ways, the fact that there has been a willingness to give voice to, I'm not necessarily the best representative, to give voice to what's happening for the poorest people, and indeed in countries where often what gets discussed in a European context is the idea that we somehow have to stop those people from heading to Europe. So that in itself, I think giving space and voice to that, I think was a very positive thing, and I've really appreciated that. I also really appreciate being in this session. I feel like I'm not necessarily the usual voice, I guess, for what you're talking about today. But I think the fact that there is actually a focus on this is enormously gratifying, because fundamentally, when people like me end up working in places like the World Food Programme, it is out of that sense of outrage in terms of who ultimately does end up being left behind. From I think this kind of question of ensuring that we properly understand the needs of communities whose voices tend to be forgotten, whose needs tend to be forgotten. This requires a huge amount of investment and effort on our side. And I think there are some areas that almost maybe have become a bit more automatic in how we think about the populations that we're trying to serve, that are perhaps can slip through the net, I suppose, when it comes to the kind of dialogue that you have in a setting like this. So the concept of, as soon as the COVID pandemic hit, a lot of our focus was really trying to expand social protection mechanisms that could actually reach and support poor communities, but equally with the work that we do on HIV, to also make sure that we were providing nutritional support for people living with HIV. And I thought it was really interesting, your point about data, because for us, quite a big starting point when it comes to ensuring that we're trying to do what we can to leave no one behind in the context where we're working, does start with data, both in terms of trying to understand who's able to access a more nutritious diet, so noting that a healthy diet often is incredibly aspirational and unaffordable, but supporting people on that pathway is really fundamental in terms of their health, well-being, livelihoods, and so on. And being able to expose who's struggling most, who's affected most by challenges with cost of living, price increases, which are, clearly a difficult reality everywhere. But also ensuring that we're using that data to hold governments and others to account for whether or not services are actually reaching those in need. So it is, I think it's an enormously important thing to make sure that we're not forgetting that. And I think with the what's coming up in the world, making sure that actors like all of you in this room and online are actually, as I keep saying this, I said this earlier, just championing the rights, needs and importance of groups that are typically those who do get left behind is so fundamentally important with, global economy as it is. It's going to be harder, not just in terms of cost of living, but also how governments are spending their resource. Again, we're very worried about that in the setting the settings that we operate in. So really trying to emphasize this point that there are groups of people who are not just going to suffer a little bit. They really run the risk of plummeting into an extraordinarily difficult place. And so it's saying, yes, we need to reach everybody, of course, but there are people who, if we don't reach them, they are going to be in an incredibly difficult position. And so the more that this can be brought into forums like this, I think it's extraordinarily important. So although my experience may be completely different to the rest of you, I'm very happy that this conversation is happening and that I'm part of it. Thanks.
So I want to go to my colleague Doro Dalig to check maybe if there are questions or comments worth bringing out from the online. And while you're checking, because I don't want to catch you off guard, we obviously tomorrow we'll have different other representatives, founding members of Nobody Left Outside, and other speakers from the forum. But we have Denis Onyango here in the room, and this is a very special panel because we ask questions to the audience here and not the other way around. The other way around will come, but because this issue of data, I think, is quite important when it comes to migration and just knowing what we're talking about and so forth. So if you can get, I'll give you a mic and introduce yourself.
So I'm Denis Onyango from Africa Advocacy Foundation, an organization working with migrants across Europe, and we're part of the collective of Nobody Left Outside initiative. And it's really interesting what you said about data, Jules, because at the moment what we are struggling with, and one of the issues that we want to raise with the ECDC but also with the national surveillance teams, is that at the moment out of probably around 54 European region countries, only around 6 are able to provide a complete set of data across the cascade of care. And this is quite important because we are looking to get to 0 in 2030. And if at this point some countries do not even get that disaggregated data, it's quite baffling. I mean, from COVID, you saw that when we were doing a review of how countries were performing with vaccinations, a lot of countries were reporting that they do not actually disaggregate the data. So the issue of data is very important because you cannot make policy or implement policy without knowing actually what you're planning for. So, yep.
And we'll see you tomorrow night, huh? So thank you, Denis. Denis is from the Africa Foundation, an organization working for migrants' rights. So, Dor.
Yeah, we actually have one question. I'm going to read that. Are there low-hanging fruit policy choices which can be leveraged to improve the health and well-being of marginalized communities? I think that goes to our NLO members. Okay,
let's do a round. Jules, you want to start, or FREEK? FREEK, if you get him started. Okay. Yeah, because it gives you some time to think and yeah.
But I don't know if it's low-hanging fruit. But for us, like if you're not an expert on homelessness, it might sound really silly what I'm going to say. But if you want to quickly improve the health situation of homeless people, you have to house them. And if you do that, you also solve the homelessness. So it's two things in one go. But seriously, like I know that the housing markets are stressed, etc. But even if the numbers are increasing, it should not be impossible, And there is countries that are making quick progress towards housing the homeless population, and you immediately see quite a big impact, and that's obvious
So
on
probably,
their health. Yeah.
So probably a better question would be, where are there some best practices than low-hanging fruits? Because low-hanging fruits are a bit mythical, but there are countries that are clearly doing better than others, especially with the one, housing first?
Yes, but there is maybe another low-hanging fruit, but there is other people in the room that are more expert on this than me. But for instance, harm reduction. When you deal with people with severe addiction problems, etc. It's actually quite low-hanging fruit because it's not necessarily more costly. You will reach the people more easily, etc. And I'm speaking against my own shop in a way. There is quite a lot of services for homeless people that are still resistant when it comes to harm reduction. So that's probably also an area where we can make quick progress. But the housing first you mentioned is actually a way to deal with homelessness that puts the traditional way totally upside down. The traditional way, which is very prominent still in Europe, is to say you're homeless, you go to a night shelter. When you behave in the night shelter, you can go to a short stay shelter. When you behave in the short stay shelter, you can actually make progress on all your other problems, your psychological problems, your financial problems, your relational problems, your addiction problems, etc. You can go to a sort of slightly longer stay shelter and then to a long stay shelter. And then when everything goes fine, you get into housing. And housing is sort of a present, a reward at the end of that integration process. And of course, it doesn't work because people rotate in the shelter sector. The shelter sector becomes enormous, becomes very costly, and it doesn't work. And Housing First is putting that upside down and say, well, we're going to make housing available for people, even homeless people, with very complex needs. And the housing will be disconnected from the services. So if you have people with addiction problems, for instance, that are offered housing, they don't have to do anything about their addiction to get into the housing. The two things are separate. And it works. Surprise, surprise, it works. And over time, it's actually cheap.
Well, actually, you have to, it works also because apparently what happens is that it also solves the other problems. That's what you mean when you say
yes, but of
it
course,
just doesn't get them a house or a roof. It also is a better way to address
but it's logical. I don't want to make it sound like rocket science. If you're in a shelter, or go from shelter and street and then shelter, and if you have that kind of life, try to reconnect with your family. It's impossible. Try to do something about your addiction problems if you're surrounded by people that have the same problems. So if you can get the security of your own home, of course it will empower you to deal with all your other problems. It's logical, but because the traditional way of doing has been done for so many decades that it's extremely difficult to change it.
Of course. So, Jules, and so it's low-hanging fruits, but also sometimes major culture change. What may seem to be a simple administrative modification actually is not so much a low-hanging fruit if the culture goes against it.
Yeah, another perspective, but very linked to what FREEK said. For example, around sex work, just decriminalizing sex work and making it okay for sex workers to actually do their job, it's going to reduce poverty and increase people to have a chance to actually either stay in the sex industry or exit the sex industry if they didn't want to end up there in the first place, and just improve their lives, and not only their lives of their children and their family and the people that they take care of. So it's just, and of course it's change in regulation, but it's also change in mentalities, change in pushing away the stigma and discrimination against sex work. And it's not just sex work, it's also, you talked about drug use. It's also for trans people to have access to healthcare and hormone therapy, for example, that are not gonna make them homeless or having to do sex work to survive, for example, being able to find a job, access a job like any job or sex work if they want to. I think it's looking at all the factors that impacts people, and there are sometimes just change in regulation and just like a little push, and it can actually change a whole like the start of like a domino I don't know how to say this, but you
A
see what I
virtual,
mean.
a virtual circle. So,
Yeah.
since we have nutrition experts, I don't want them to miss out also. There is the issue of non-communicable or chronic disease, non-communicable disease. There's a lot of efforts at the high level in policy making to address NCDs. So what is happening? Are we seeing progress? Prevention being better than the cure, but it's as old as it has rarely been fully implemented, I guess, but I'm not an expert.
I'm happy to start. I mean, again, you know, for the countries that I work in, NCDs are a growing challenge, and the quality of diets is a growing challenge. And the tough reality is that when we talk about choice is being fundamentally shaped by the profits of the private sector, of the food industry, of a lack of neglect to this consideration of how we can actually orientate our food system so that healthier foods are more affordable, are more accessible. We've got a very long-standing trend of investing in the less healthy parts of the system. There was a report that came out a few months ago, the State of Food Insecurity report, that talked about repurposing agricultural subsidies, recognising that that in itself has also really orientated our food system so that when you talk about choice and what people will walk into their local shop or into their local market or wherever they're able to buy food, what's there is not fundamentally healthy. And this is where we need some really radical action. And I haven't heard this in this conversation. It's not a conversation you tend to hear very often, because fundamentally, when you talk about economies growing in the short term, unhealthy foods and consumption of unhealthy foods continues to make people a lot of profit. And whilst that is what matters most when it comes to how governments get re-elected, we're stuck. So we really need some very radical action on this to say, you know, healthier diets, it's not just this aspirational thing that we, you know, only a few people should have. It is a foundational point of, you know, health, well-being, no matter who you are. So I think, you know, measuring our success on kind of the radical action needed to make that a reality. I think that's what we should be doing. But we're not where we need to be by any stretch.
But there has been quite a bit of conversation, at least, you know, for the last 10 years in the US about food, you know, healthy food desert and areas where it's just not possible. And maybe, but I want to hear also from Doro, because time is running. We have a short session. So
yeah, I'm gonna be quick. I couldn't agree more. In the countries I've been working with, which is in the European region or the EU, not a single country is on track of stopping the rise of the NCDs, be it poor diet-related NCDs, mental health, etc. That's also a growing problem. So everything that you've said is also affecting our societies, everybody really, pretty much in the EU. And yes, some people are better equipped, better supported in having access to healthy, on being able to afford a healthy and sustainable diets, while others simply cannot afford it. And yes, there's been research done. The cost of healthy, sustainable diets can grow up to 70% or something of people's disposable income. So it's there's clearly something wrong, and making the healthy, sustainable food cheaper is one of the ways to go forward.
So this is at the population level, of course, and as we've heard already, the challenge when it comes to marginalized communities is this, you know, vision of the population level solutions. How many people are left outside? In fact, not thought about, not measured, and never addressed. So perhaps I know that there are some striking figures in terms of life expectancy and burden of disease in some of those marginalized communities. So maybe you can share some.
Yeah, it's
thoughts.
a very tricky question, Boris. I wouldn't like to use the sort of life expectancy measure, because it's extremely difficult for homelessness. Also because people are not homeless their whole life, you know, they're in and out of homelessness. But where we have data is if you look at the average age of death while people are homeless, so if you're on the street or in a shelter, when people die then, it's less than 50. And it's lower for women than it is for men. That's already a striking statistic. And these people usually don't die because marginalized communities are often linked with infectious diseases. And I don't want to underestimate how important that is. But these people that I'm talking, they usually don't die of an infectious disease. They die of an NCD, we say.
Chronic disease.
A chronic disease can be cancer or whatever. And I think we'll have to do an effort to link the marginalized communities more with the chronic diseases. Also, we have to do our work there as well. But it's really an issue.
All right. Jules, maybe you have something about NCDs and the whole issue of access to healthcare, and you mentioned some part of it, but long term, we're all faced with chronic disease linked to aging. So, is there a specific thing with sex workers in their challenge to live longer, healthier lives?
I think what's struck me also in also hearing the conversations today about social determinants of health is how can we be healthy when we live in fears of being arrested by the police, of having our children taken away, of potentially being deported because we are engaging in sex work. I think this brings a very huge amount of stress, and it has also a lot of impact on mental health. It's also a topic we are working on at ESWA quite a lot on what are the, sex workers face a lot of mental health issues, not only sex workers, but also activists in the sex worker world. And also just in terms of figures, something that struck me is I think the average, I think the life expectancy of a trans woman in the world is 35-year-old. So when a trans woman reaches 35, it's already a big, obstacles that she managed to go through. And I think this actually tells us a lot about how come that it is such a short period of time for someone to be able to live. And it really talks about the stigma and discrimination of some marginalized groups. And I think if something that we really need to remember is no matter our moral views on sex work, on gender, on sexuality, on drug use, I think we need to find ways for people to be safe, for people to live longer, for people to be healthier. And I think when we go from that point of view, a lot of things around criminalization will be solved, because this is more moral point of view on all those things I mentioned.
Right. So I think we have a few minutes left. Sorry, I didn't turn too much to the room, but if time allows, if anybody has a question, please raise your hand. We'll bring the mic. Otherwise, we'll be around during the conference. Oh, there are some questions up there. I'm not hybrid.
Can I make a small point for it?
Yes, please.
It was more like a call for action because, hello everyone, I'm Luca Stevenson. I also work for the European Sex Worker Rights Alliance. It was more also like a call for actions because I feel like you all work in a public health or institution, and we talk a lot about marginalization and discrimination in society against our communities, but discrimination are often reproduced at the level of institution as well. There is very few health work plans at the national level that do include our communities. And I feel that's why our message, I think, would also be for you to, at your own level, to see what you can change in your institution to create space for the communities to participate. So lots of our organizations are organized at national level. You will have sex worker-led organization working. We have 100 members in 30 countries, which are led by sex workers or working with sex workers. But often they are not at all involved in any kind of discussion with governments. We saw that during COVID crisis. Very few governments approach sex workers what can we do to make your life better during this crisis? And I feel that's something that can really be done from the small, the services for sex workers, the service general health services, to health institutions, to Ministry of Health, and to the European level. So I think it's not just a challenge, because sometimes we push this issue away from us. We're like, oh, there's lots of discrimination against this population. A lot can be done, but actually a lot can be done directly in your everyday workplace as well. Thank you.
Great. And Doro, you have some? Oh yes, please.
Just thank you so much for actually this call to action, because lesson learned for me, or the key take-home message, is that what I'm going to do is I'm going to go back into my organization, which is a collection of these national public health institutes who are, in a way, involved in design, implementation of the national health work plans in different areas. And I think that's for the public health community at the national, regional, local level to step in and be actually more present and facilitate those spaces. But what I wanted to say also is that, and you, Boris, said it, that it's wonderful that the Commission and the Health Forum Grashstein enabled us to sit here today and last year, etc., and the Commission to run the thematic network. But what I want to say is that there's so much money at the EU level. We are going to see a joint action of member states on health determinants and NCDs worth 75 million euros to start as of next year. And where are the voices of the marginalized populations and communities in there? It's like it's incredible. It's incredible, and all the research projects. Ever since EuroHealthNet was involved in the LGBTI for Health project, I believe in 2017 or 18, I have particularly not really heard of anything happening, collecting data, and illustrating the needs and meeting the needs of the sorry, just getting very emotional.
Thank you.
I share your frustration, of course, every day, actually. But there is another, apart from the money, of course there's money enough. It's a question of political will, and not even political will, because often at the level of the commissioners, that is the will. It's more the administrative will inside the commission that is the obstacle. But apart from the money, there is also, it's a perfect issue to focus on, because it fits well with the principle of subsidiarity. We are not asking legislation at EU level. We're asking to organize learning, and the learning potential in this area is enormous. Like, there is so much need for more research when it comes to health for these groups. Best practice, etc., they can really have an impact, because there's so little scope and there has been so little done in the past to bring these communities together, or experts that work with these communities. So I think it perfectly fits what the European Commission can offer. So the money will be well spent, and there will be definitely impact. And that's the argument we're trying to make with NLO since 5 years. And I think we're gradually making progress. But there is still need to further push. And if EuroHealthNet can help with that, perfect.
Great. Well, those are perfect concluding words, although I never know how to stop. And I would just, keep in mind something. We had only 2 members of the Nobody Left Outside coalition tonight. We'll have others tomorrow night. And for example, on the question of low-hanging fruits, we didn't have the people representing prisoners and healthcare in prison. And if you just think about it for a second, those people are actually in prison, and there is a lot of opportunity for healthcare in this setting, but is that a low-hanging fruit? I don't know. But just so that we've talked about certain communities, but there are others also communities that are faced with a dramatic challenge in access to healthcare for reasons that are often are not just because it's very complicated. So. Thank you very much for joining us tonight. I promise you that tomorrow it will be completely different and you will learn new things. So please come back.